Hi, everybody. Thanks for coming to my talk. So I'm going to be talking about cannabis medicine for children. I think you guys all know my background, so I'm not going to spend any time on that. But I wanted to do something a little bit different today. I think just even for my own entertainment to mix it up a little bit, because I talk about a lot of the same things over and over. And I'm sorry to those who were here Tuesday for the practicum, there will be a little overlap, but I do try to go into more detail since I have a little more time. So I wanted to start with something. I've been doing this now about 14 years, and I've been a physician for 30 plus years, and I just want to share with you all a few things I've learned working with cannabis and working with sick people, including very sick children. And so this is like my favorite part of my show right here. This is why we all do what we do, and thank you to all the researchers, to Medical Genomics for putting on this conference, for all the sponsors, for everybody here who does their part in cannabis. I know we're all like-minded, and these are the most vulnerable patients, and some of these kids have cancer, some have epilepsy, some have autism, some have irreversible brain damage. This is why we all should be doing what we're doing. And I know we all have our stories. We have our mother was sick, or our best friend, or our brother, but really this is what drives me to try to make it better, to try to get better products, to try to get more research, and so on. So I'm just going to tell you about a few things I've learned. So sorry about that, other things shouldn't be there, but I guess I screwed up on my animations. But what have I learned? Cannabis is good medicine, right? Now you could say it's great medicine, but I say good medicine, I'm talking about, when you say, oh, that's a good person, or she's good people. This is good medicine. Why is it good medicine? Because we routinely witness improvements in symptoms and quality of life, even when you don't even know what you're doing with it, right? You can go in and buy some cannabis and walk out and you say, oh, I didn't know what I was doing, but I slept great, and I was nicer to my husband the next day, and I didn't yell at the kids. It's important to know that. Many people are able to lower doses or discontinue other medication. How many here know somebody, whether it's a family member, yourself, or somebody you've helped? Raise your hand if you know somebody who's been able to stop or lower a dose of other medication, right? Just about everybody who's worked with patients or just even talking to people. And then also, patient satisfaction is exceptionally high. It's easy to say this anecdotally, but there was a study back in 2014, 86%. I don't know of any other drug where you get an 86% patient satisfaction, and that's because even if you miss your dose of cannabis, likely nothing bad is going to happen. If you overdose on it, likely nothing bad is going to happen. So it's a very easy medicine to work with, and I'm still kind of I think I said this on Tuesday, I'm kind of over it already, trying to convince people. We have enough data and enough research to show that patients want this. There's a study out of Stacy Gruber's group with, I think it's how you say cigar. 12 months of medical cannabis resulted in significant improvements on measures of executive function and clinical state, including sleep, pain, and quality of life. These are people who were measured and tested, and Stacy talks about them being the most studied group of patients on the planet before they start medical cannabis, and then she measured it at 3 months, 6 months, and here's her 12-month study that came out last year. Clinical improvement was associated with higher CBD use. Cognitive improvements were associated with clinical improvement. And what they concluded was medical cannabis patients may exhibit enhanced rather than impaired executive function over time. We see this over and over. I see this in my pediatric patients. They take mega high doses of cannabis, and guess what? They can finally get back to school and learning. It's the exact opposite of what we have been taught and what we've been propagandized over all these years. Second thing I've learned, medical cannabis is safe. Now, you could argue with me about problematic use or misuse, that's fine, but I'm talking about medical cannabis, someone who is using it specifically to treat medical condition. And so I wanted to show you the kind of world we live in. So when you think about medical cannabis and people get really, I still get from people, really? Oh, is it safe? Oh, I don't know. The world we live in has drugs that are so scary. Look at this. A new anti-epileptic medication is linked to turning you blue. There's something called blue person syndrome. Okay, now luckily this was taken off the market, but how this got through our regulatory institutions is beyond me. I mean, I guess it's okay if you want to be blue, but I don't want to be blue. How about this one? Painful erections while being treated for OCD. I don't know, you're talking about trading one condition for another, yes? This is a great one. Warning, this Parkinson's drug can make you addicted to gambling, sex, or food. So I read this article, and this poor elderly woman who's struggling with Parkinson's turns into a gambling addict. She lost $250,000 at the local casino on the slots. And when they discontinued the drug, guess what? She never gambled again. But yet this is acceptable, and I find that fascinating. And then here's my favorite, everybody. Loss of fingerprints, okay? And this is with a cancer drug, and hopefully none of you ever have to take this, but I don't know, pick your poison, right? Cannabis doesn't do any of this. Help with the slides? Am I doing something wrong? It's stuck. How do I unstuck it? Oh, there we go. Okay, so I just pulled out a few articles, and anybody who sits and reads the medical cannabis literature, you're going to see these words over and over and over again. Safe and efficacious, well-tolerated, mild side effects. We really don't see blue person or loss of fingerprints or gambling addiction. Here's a study that showed over 2,700 elderly patients, safe and efficacious, and look what it says. Cannabis use may decrease the use of other prescription medicines, including opioids. Here's another one. 2,900 cancer patients, cannabis just for palliation, well-tolerated, effective, and safe, but 95.9 reported improvement in their condition. Here's another one. This is 367 fibromyalgia patients. Medical cannabis appears to be safe and effective. And here's another one. For autism that just came out this year, a review of cannabis for autism. Cannabinoid therapy for autism is associated with low adverse side effects and reduction in concomitant medication. And if you read through the literature, and even if you just sat for an hour looking, you're going to see these same words over again. So this idea that cannabis medicine is fringe, that it should be last resort, it's just a bunch of nonsense. This medicine is safe and well tolerated, especially under medical supervision. And even without medical supervision, it's usually very safe and well tolerated. How do we keep it safe? All right, so see somebody who does a medical history so they know what drugs you're taking, they know what treatments you tried, they do a physical exam, a review of all your medications and lifestyle prior to onset so you can get the best result possible. Only use tested products that have a transparent COA. If you don't know what's in it and you can't reproduce that, it's unlikely to be sustainable medication. I had a patient a pediatric patient who has seizures. In fact, his picture's one of the pictures on my initial slide. And his mother was afraid to tell me this, but she eventually told me that she was taking the oils like I had recommended, and then a cousin handed her a little bit of RSO oil, and she just decided to give it to him, and he had a significant reductions in seizures. Had she told me about it, we could have gotten it tested and figured out what it was. She used it up, told me about it 6 months later, and I was like, well, that's really not medicine because you don't have it anymore. So it's very important that we're using products that we know what's in it, we know that it's reproducible and consistent over time. Start low and go slow titration prevents THC dosing errors. This is important in pediatrics and elderly patients and really anybody who is still a little skeptical. Just this past Thanksgiving, I have friends who I've told them never give a gummy to an elderly person without cutting it into pieces, but they didn't listen. They gave, the night before Thanksgiving, he gave his mother with sleep problems and anxiety and depression a 10 milligram gummy, and she basically had a terrible reaction. Thanksgiving was canceled the next day, and they just kind of babysat her, but now she's turned off to it. So remember, start low and go slow, especially in those patients who are cannabis naive. Side effects are very rare with non-impairing cannabinoids like CBD, CBG, CBDA, and so on. Also, side effects are easily mitigated. Everybody's heard me say this. Change the dose, change the timing, change the product. You can mitigate. You don't have to have side effects. First time you're trying something new or someone you know is trying something new, they should be at home. They shouldn't have like a test in 2 hours, right? Or, you're meeting the in-laws for the first time. You want to try it at home first, see how you feel. Even something that you know may be non-impairing, you may be sensitive to it, so it's important to keep it safe that way. And then get help if you don't know where to start or you haven't found relief. There's so many healthcare practitioners here today. There's so many nurses and nurse practitioners, so many people to ask for help. So please ask for help if you're not sure what you're doing. Or if you think you're doing it right and you're not getting relief, it's helpful to bounce it off someone else. All right. Everybody knows this one, treat the patient, not the diagnosis. We do like to have an understanding, if you have this condition or that condition, that maybe you should go in this direction or that direction is dictated by clinical experience or by the latest scientific information. But in general, we know personalized individual regimens based on a patient's response is the way to go with cannabis, and one size does not fit all. And I'm just gonna show you this slide here. I'm gonna be talking about this. This comes from my autism research. And you can see the patients age 6 to 12 kind of listed and what sex they are and their dosages per day. But if you look at the cannabinoid content, these are all children with autism. None of these children have epilepsy because that was an exclusion criteria in our group. But you can see they're all on different cannabinoid regimens. How did that happen? Well, we followed my rule it in or rule it out. You start with one thing, you titrate up, you look if there's any benefit, what dose is that at? Can I do better than that? Now, often with most patients, you hit a point at which you start to have side effects, and then we know that you're at the ceiling dose. CBD can have a ceiling for some patients. I have patients that get GI upset if you go past a certain dose, or they get very sedated if you go past. That's their ceiling dose. We're going to stay below that. Let's say that only helps them 75%, they're only 75% improved. Well, there's room for improvement. Then we add a second cannabinoid, or we might try a different product within the same category. All of these patients were on cannabis for at least a year, and during that year, or even if it was longer than that, we worked on ruling it in, ruling it out, dialing in on the products. So always don't ever think that just because somebody has one diagnosis, this is what they should be on in the cannabis world. It really should be dialed in, and certainly what's happened now is that when I first started doing this, it was really just THC on the market, and then around 2013 there was some CBD available, and then we started to see the other compounds come out. Now there's so many to choose from, so it makes it a little more difficult. But pick one, start there, and then go through. And that's why I always say it is worthwhile if you're dealing with a significant medical condition to have at least one consultation with a doctor, nurse practitioner, somebody that knows about this, that can at least give you the lay of the land. Where does the research stand? And what should I be looking at? So just to get some signaling on that. All right. My next is take care of your gut and you will have a happy endocannabinoid system. They are intimately related and is very important. You cannot say, oh, I'm using cannabis and it's not helping me while you're eating a cheeseburger and french fries from the greasiest place in town. You have to help your gut to move forward so that you can have a healthy endocannabinoid system. And so there's an article that came out last year that here's a quote, the endocannabinoid system encompasses a key interface between the gut, microbiota, the immune system, and homeostasis of the human host. Very important for your gut to be part of this. Endocannabinoids and phytocannabinoids modulate gut inflammation in the microbiota, stabilizing the blood-brain barrier pathway and reducing neuroinflammation. When you think about inflammation, we are I once had a doctor, an oncologist, tell me that we live in a cesspool of chemicals right now. By the time you leave your house in the morning, you've probably been exposed to 300 chemicals. You might not be able to control some of that, but you can control what you put, as my friend says, in your pie hole. So it's important to understand that you want to take care of your gut. And here's just a nice graphic of, this was a article that looked at how HIV affects the immune system, the gut, and ultimately the brain. But as you can see, what's at the center of all of it? The endocannabinoid system. And if you're using cannabinoids and you're not finding benefit, think about taking better care of your gut. It's important because between those two things, you can often mitigate illness. All right, and then there's two very nice articles. So Dr. Russo's Beyond Cannabis Plants and the Endocannabinoid System, excellent, talking about this very thing. And then also an article that's a little bit older, but I find it to be a really great article, The Care and Feeding of the Endocannabinoid System. So two very nice articles that are help you understand the interplay between the various systems in your body and your endocannabinoid system. And then, let me go back one here. So my number 5, and before I get on to the kids, is respect your receptors. So I've been joking around about this for years. Respect your receptors. So what this slide shows, I don't know, let's see, is there a pointer? I don't know if you can see. I don't think it's working. But anyway, what you can see here is the cell. And on the cell wall are cannabinoid receptors that you can see. They kind of look, they're the like little neon yellow. And then JWH0108 is a synthetic THC-like compound. So it binds to the type 1 receptor. So what you can see on there is that this is showing acute administration in a cannabis-naive rat. And if you give them this compound, all of the JWH goes ahead and sticks onto the cannabinoid receptors. And then what happens is with chronic use, look what's happening here. So we went from a whole bunch of receptors on the cell wall to just a few. A lot of the compound, the ligand, is still floating around looking for a place to bind. And if you'll notice, the little neon cannabinoid receptors are now internalized inside the cell. And this comes from this is the concept of tolerance, okay? Sometimes downregulating your receptors can be helpful, but for the most part, if you want a good medicinal effect, you want to try to maintain a decent amount of cannabinoid receptors that are not downregulated. And so in the medical world, I don't see too much tolerance, but here and there I do, especially those patients who happen to be THC responders. There are people out there that do very well with THC. I always try to include some CBD in there because it does seem to help mitigate some of the tolerance. I always hate to do what we call a tolerance break, especially let's say in a child who's getting very good results with either epilepsy or autism, because if you take away their medicine, what happens is they end up back at their baseline prior to cannabis use. And so parents will say to me, oh, there's no way I'm doing a tolerance break because I can't do 48 hours of horrific behaviors because I've now lived 3 months without that. It's like it's causing them more trauma. So what we do is we do try to use other tools, so changing chemovars or adding in non-THC cannabinoids to try to help do some of the heavy lifting to try to help maintain the receptors. And then when I often talk with teenagers, so if we get teenagers that come in who, as I said the other day, they know more than me about their endocannabinoid system. So they just think all THC all the time. And what ends up happening, I actually had a child who ended up suicidal. He was home, I put him on, I said, you can use your vape pen to go to sleep, that's fine, but you have to take your CBD in the morning. He had terrible anxiety, depression, and had one suicide attempt years prior, and was just reluctant to take any more pharmaceuticals, and he was okay with using CBD added in. And after about a month, he decided, I don't want to take the CBD anymore, and he's a 17-year-old boy, so good luck getting him to take it, and the parents weren't really paying attention. And next phone call I got about a month later was he was being held on a 5150 hold for suicidal, but what he had done was totally escalated his THC use, dabbing and whatnot, the whole rest of that month. So, I feel very strongly about this, and I joke around for years that I was going to make a t-shirt, and there's your t-shirt. Respect your receptors, people. So, okay, let's get on with the talk for children. And I just want to point out, this is one of my patients, a teenager with epilepsy and autism, drew this picture to tell me just how much cannabis impacted his life. So how nice is that? Isn't that a beautiful photo, or a beautiful picture that he drew? So the most common conditions we see in pediatrics, by far intractable epilepsy and autism, they often run together. Also cancer, either for side effects or to treat a child who has been given a very poor prognosis. GI disorders, attention deficit and Tourette also, anxiety, depression, chronic pain, genetic conditions, and certainly end of life. I'm going to focus on epilepsy and autism. That's where we have the most data. A 2000 study done by Quan and Brody showed only 64% of epilepsy patients respond to medications. And then they repeated the study in 2018 to see, since there were many new anti-epileptic drugs on the market, and they found the same thing. Overall outcomes in newly diagnosed epilepsy have not improved, and more than 1/3 of patients experience epilepsy that remains uncontrolled. And this is where we have to think out of the box. I have many patients that are up for getting brain surgery or a device implanted in their chest. And I always say, why not try the benign plant first before you do anything invasive? I have one child who has had 3 brain surgeries, and she was good for 1 week after the brain surgery, and then the seizures came back with a vengeance. I'm not sure how they go back 2 and 3 times, because this is certainly not reversible. Cannabis has been somewhat helpful for her condition. This is just a graph that I made looking at the number of publications. If you just Google cannabidiol and epilepsy or go to PubMed and you look at the research, look at kind of where it correlates. And you can see 2013 is when CNN aired the Weed documentary with Dr. Sanjay Gupta, and it was kind of opened the floodgates a bit as he gave the stamp of mainstream approval there. And as you can see, the scientific and medical community has responded with research. So bravo to us, all of us who have participated in that. And now certainly clinical research supports the use of CBD to treat refractory epilepsy. This is now considered to be a very viable anti-epileptic drug. And I'm just going to go through some of the latest studies from the past couple of years that summarize what we have learned over the last decade of watching and listening and researching CBD and other cannabinoids for epilepsy. So Gaston et al., they used purified CBD in 89 children and 80 adults over 2 years, and they saw a significant mean reduction in seizure frequency at 1 month, 1 year, and 2 years, all highly statistically significant. And you can just see greater than 50% seizure reduction is considered the clinical standard. So you can see in children, 1 month on CBD, 46%. And it goes up after 2 years. So if you have patients in the beginning that are saying, well, we're not getting the best results, hang in there. Look, in adults, it went from 31% to 52%. And some of that also, too, is, of course, dosing, titrating up slowly over time. There was a significant difference in seizure severity reduction at 1 year, with adults reporting greater improvement in seizure severity, and that was highly significant as well. And here you can see just 2 charts. The first chart is the percentage change in seizure frequency, and you can see on the axis there the percentage reduction from baseline. So from 0, and it drops how down. So it's minus 60, but that's the percentage reduction, and this is over time, over 2 years. And you can see adults is the dashed line, and pediatrics is the solid line, and you can certainly see that in terms of seizure frequency, it's almost equivalent, but in the second graph, you can see that adult severity went down. And that's important because often these are people who have struggled with seizures their whole life and have not had any good results. Okay, how about EEG changes in effect on sleep? So CBD use decreased interictal epileptiform discharges. It's a mouthful. But this is basically evidence of a neuroexcitatory brain that was highly significant. And then CBD use improved sleep microstructure in 84.6% of those patients with abnormal sleep. Again, a very high number. Here we have an evaluation on cognitive and behavioral tests before and after CBD. So this was before and after just 3 months looking at patients. 89% remained stable or showed reliable improvement after 3 months on CBD. Very high percentage, right? Cognitive and behavioral changes were not significantly correlated to the CBD dosing, which is always very interesting. Improvements in short-term and working memory significantly related to better therapy response, and there was no adverse group level effects on CBD reported in this study. What about long-term? So there was a signaling maybe around, I want to say there was a study that came out of Israel a few years ago that said maybe CBD effects wear off after 3 years. And I would tell you that here and there I saw patients who maybe at the 2 or 3 year mark seemed to maybe lose efficacy. And remember, in children, they're also growing and changing and hormones and so on. So what is it? Is it the medicine that doesn't really work after 3 years? Well, we have now this study published last year. CBD does not lose efficacy during treatment period up to 5 years. Most patients in their group were able to at least decrease the dose of at least one other pharmaceutical that they were using for epilepsy. And certainly, again, here's those words, well-tolerated, effective, and safe for long-term use. And so that definitely gives those people out there who are still reluctant to think about CBD as an anti-epileptic. It gives us the assurance. And I'm just going to share with you, so I trained at Children's Hospital right here in LA, and I gave grand rounds the month before COVID hit. Nobody from the neurology department would come to my talk. Okay? Yeah, they boycotted my talk. Now, it was standing room only, but the neurology department actually said to the head of the hospital, how are you even justifying this? This is what bothers me. The literature's there, right? The support is there. So just be aware that we're still in that uphill battle despite looking at all this research. All right, and here's one that came out looking at an observational cohort study of epilepsy patients using, this is artisanal CBD. So this is CBD from whole plant. 280 patients using CBD and 138 who did not. And compared to controls, the CBD users had higher quality of life, lower psychiatric symptom severity, better sleep, better medication tolerability, improved health outcomes longitudinally, use of fewer prescriptions, and reduced healthcare utilization. I think I'm beating a dead horse here, right? So I think we've figured out what's going on. Now, Dr. Russo mentioned this the other day, Pamplona's study looking at CBD-rich cannabis extracts over purified CBD in treatment-resistant epilepsy. And this was a review of 11 sources with 670 patients pooled. The CBD dosing range was very wide, 1 to 50 milligram per kilo per day. And that just tells you about CBD's very wide dosing. If it doesn't work at a low dose, go up. And the treatment length on the mean was 6 months. 64% reported improvement in frequency of seizures, and there was more improvement with the CBD extract, 71%, than with the purified CBD at 46%. And this was statistically significant, but if you apply what's called the standard clinical threshold of greater than 50% or more reduction of seizures, there was no difference. So then I ask you, well, if there's no difference, then what are we going to do? How do you choose? Go ahead and look. CBD extract patients use a significantly lower dose, 6 milligram per kilo per day versus the purified, which is at 25 milligram per kilo per day. And in terms of the side effect profile for artisanal CBD was significantly better than for purified CBD. I find the only reason that I'm referring patients now to get the purified CBD Epidiolex, and it is only approved for 3 conditions right now, which is Lennox-Gastaut syndrome, Dravet syndrome, and tuberous sclerosis. But they will, you can get it off-label for other severe epilepsies. What I'm doing is when a patient needs a very high dose, like we're talking 1,200 milligrams a day or 1,600 milligrams a day in some of my big teenagers, that is very difficult to afford. So what we do is we will do some of the dosing as Epidiolex, that is, they get help. It's part of the insurance company, and the other part we do with the whole plant. Nobody ever said you can't mix them. So I do, and it works out well, so the parents don't have such a high financial burden. And so I initially wasn't too happy with Epidiolex because I don't like that there's alcohol and some sucralose in it, which is not great, but at the same time, if it helps a family with the burden of paying for a high dose and keeps that child off a multitude of other anti-epileptics, it certainly is the lesser evil of Epidiolex versus other drugs. So. All right, and now let's move on to drug-drug interactions. This was a big concern when I first started doing this. We really didn't have any data, so we were super, super careful with patients. This is a review of 6 trials looking at the interactions between cannabidiol and enzyme inducers or inhibitors and common anti-seizure drugs. CBD in this study or review of these 6 trials was not found to affect the CYP3A4 activity, except for the case of a drug called Clobazam. Clobazam, the brand name is Onfi. It's a pretty potent benzodiazepine. It's a heavy-duty drug. It causes a lot of sedation and slowing down of a child's brain, but it can be quite effective for seizures. When you mix CBD and Clobazam, Clobazam is a drug in and of itself, but it's also a prodrug in that when you take it, your liver converts Clobazam to a secondary metabolite called N-desmethylclobazam, which is an anticonvulsant in its own right, but N-desmethylclobazam is heavily sedating. CBD seems to drive the liver to convert more Clobazam to its metabolite, N-desmethyl. So you can't just give somebody extra of that second drug. The liver has to make that. And so what happens when they're taken together is there's an increased exposure to the major metabolites of both compounds, which can be beneficial for the patient because now the patient's getting more of that secondary metabolite, which is anticonvulsant. And if they respond to that, sometimes by adding CBD and boosting up that N-desmethyl, you will see some improvement in seizures. And you don't know whether it's the CBD or the other or both. Sometimes you have to reduce the dosing of Clobazam because as you drive up that secondary metabolite, the patients can get very sedated. 40% of patients in the Epidiolex trials require dialing back of their Onfi dose. And so it doesn't happen right away. It's not like, oh, we up the dose of CBD and the next day the child's sedated. It is usually a week or 2 later. CBD and valproate, so this is valproic acid or Depakote. There's been a lot of talk about that because in the Epidiolex trials, they put in acute liver injury because they did see some elevation of the tests looking at liver function and liver enzymes. But in this review, it did not cause clinically important changes in the pharmacokinetics of either. I will tell you that in my patient population, Depakote is very popular. It's being used by many neurologists, and those children usually get blood work every 6 months anyway. I have yet to see any issues. I know in the article that Dustin and I co-authored with Dr. Sinedo out of Seattle Children's Hospital, he's a neurologist, he did not see any changes in liver tests in children taking artisanal CBD, and I just haven't seen it. It seems to be more so related to the Epidiolex. I never say never, I just haven't seen it myself. Only time I've actually ever seen elevated liver function tests in patients taking very high dose CBD is in children who are also on liver toxic chemotherapy. So that combination can cause that elevation as well. And so their conclusion was, quote, these trials indicate an overall low potential for drug-drug interactions between CBD and anti-seizure drugs except for Clobazam. All right, now let's talk about Delta9 Thca, which I'm going to call just THCA from now on. It was first mentioned back in 1979 in a mouse model of seizures, and it was anticonvulsant at 200 milligram per kilo. And then, of course, there's many anecdotal reports, and I have many patients that take THCA as either their main anti-epilepsy drug or as part of their regimen. A study that came out this year used highly purified THCA or a mixture of THCA and THC looking at mice that have what's called Dravet syndrome, which is a severe genetic pediatric epilepsy, very, very difficult to treat. These children have heat-induced seizures. I once had a patient, my air conditioning in my office was out, and the parents came rolling into my, the child's in a wheelchair, I say rolling in, and they felt the temperature in my office and said, no way are we even sitting in this room because she will have a seizure. So those kids are that sensitive. The mixture was found to be anticonvulsant in what's called the 6 Hertz threshold. This is for partial epilepsy, this kind of test in the mice. And pretty much on everything else, it really didn't appear to work. It's always important to look at dosing and what does purified mean? Does that mean there really isn't any THC in there, or maybe there's still a little bit? Because remember, THCA wants to change to THC, so it's very hard to study it all by itself. But certainly in my in clinical practice, THCA does help a lot of my patients, and because it's either has a higher potency or because it's more bioavailable, you can take a lower dose. It's easier to get into the body than CBD. Now, looking at CBDA, the first published report of its anticonvulsant activity was actually in a patent back in 2019, looking at a mouse model of generalized tonic-clonic seizures. We think the mechanism of action is enhanced serotonin receptor activation, which appears to be even better than with CBD. And then in this study, which is again a mouse model of Dravet, the CBDA brain plasma ratio in an oil vehicle, so this is CBD in just an oil extract, which is usually what's available on the market, this low ratio suggests poor brain penetration, but the question is it hitting serotonin receptors in the gut, which is then talking to the brain? But the CBDA, they tried another vehicle, which is something called tween-20, which is a non-ionic surfactant emulsifying agent that's often used to stabilize oil and water extractions or preparations. The brain plasma ratio was much higher, and in this, with this product, they found it was anticonvulsant against the heat-induced seizures in this Dravet model. And then another study that came out looking at the mouse, what's called the MES seizure. This is for generalized tonic-clonic seizures. They compared 3 different products. So look at the first product that they labeled Clobazam. That's what they called it. So it's almost 75% CBDA and has other minor cannabinoids. And then they used magnesium as like this kind of a binder to help penetrate through the lipid layers. And then they used a purified CBDA. And I want to point out to you that in the Clobazam, you see 75%. And in the second one, you see almost 93%. So the second one is a higher potency, right? And then they compared it to basically a CBD isolate. And what they found was the cannabinoid was more effective than the kind of pure CBDA in reducing seizures. And this supports the entourage effect, because the lower potency but with the minor cannabinoids seem to work better than the higher potency. So that supports the idea that when you have that whole plant, that you can actually let all those compounds do some of the heavy lifting for symptoms. And then they also found that it was comparable to CBD. I have started using CBDA in my pediatric patients, and I am seeing some of these patients have good results, not only for lowering seizure frequency, but also severity and duration, as well as parents starting to report they feel like their child has less anxiety and also sleeping better. So again, it's hard to know when you're adding something into an already established regimen. Is it synergy? Is it that compound? Again, very hard to know, but when we're going in the right direction. And by the way, too, I'm also seeing some good results in the kids who have autism who don't have epilepsy with CBDA. Mostly the most common report is my child's less anxious. And so I'm finding that I've now kind of moved CBDA up in the list of what to try, a little bit higher priority. All right, and then let's just talk about THC for seizures. A lot of neurologists are telling patients, oh, THC causes seizures, even a low dose, and I just don't see that. And we don't see that being borne out by the research. So in preclinical findings looking at 6 species and 34 discrete animal models, 21 studies found anticonvulsant effects, 1 study proconvulsant, 1 mixed, and 11 studies didn't find any effect on seizures. A report from 2016 was observational, looking at 292 adult patients, 190 with epilepsy, 64 with what's called psychogenic non-epileptic seizures, and 26 with both. These were patients who mostly inhaled about 1 gram a day. 84% of the patients using THC reported improvement in seizures. It's a very high number. Almost 73% of the ones with psychogenic non-epileptic seizures reported improvements. And then here we have a study just from 2 years ago looking at retrospective reports of using THC in patients with what I would call severe intractable epilepsy. So a 21-year-old with epileptic, and this comes out of Italy, epileptic encephalopathy since infancy. The seizures went from 20 a month to 7 a month with THC alone. An 18-year-old with West syndrome with another severe pediatric epilepsy since infancy, reduction of seizures from 13 a day to 2 a day. And this last one is amazing here, a 25-year-old with juvenile absence epilepsy and rare, maybe twice a year, generalized tonic-clonic seizures went from 20 seizures a day to only 4 a month. Very impactful for that patient and certainly for their family. So we think the mechanism of action is decreases glutamate via CB1 activation. I'm sure there's other mechanisms, but I find THC to be very clinically helpful in my pediatric patients. Sometimes just adding a little bit reduces seizures. And also if they're weaning off anti-epileptic drugs, they're going to have withdrawal. Those drugs are very difficult to get off of, and I use low-dose THC. Parents, we usually put the kids on some regular regimen, maybe morning and night, but I also tell the parents, you can spot treat anytime, as needed treatment when you see your child having any difficulty. And remember, you don't have to stay on that. That's something just to get them through the weaning. And often parents seek benefits and say, oh, can we just make it part of the regimen? And so it's just easier for them to have it part of the regimen day to day. And then, of course, there is some tolerance that can occur if it's the only medication that's being used. There's a little boy I take care of that has a multitude of medical issues, and the only thing that's helped his seizures is THC, but he's on a very high dose. We're still getting good control, but I'm a little afraid that we may lose the medicinal effect, but we'll just have to wait and see what happens. Now, we're going to switch to autism. So the CDC now, the latest number is 1 in 44. It was 1 in 54 the last time I spoke in person, so that's a little disheartening. Boys are 4 times more likely to be diagnosed than girls. There are no approved medications to treat the core symptoms. There are 2 FDA-approved medications that treat irritability. They are atypical antipsychotics that have a lot of side effects. Also, off-label medications like stimulants, antidepressants, anti-anxiety drugs are being used, but often have low efficacy and a risk of side effects. New pharmaceutical studies show low efficacy except for crossover. There was one study reported in this report this year that said all these other drugs aren't really working, but the cannabinoid study shows promise. So that's always good to be included. And then we know these patients have more inflammation, including neuroinflammation and gut issues. So I'm going to speed up a little bit because I want to get to my research. This is another graph just to look at when did we start seeing publications on autism and cannabis, and it's not so long ago, right? 2019 is really when it took off, just a few reports before that. So there's a lot of interest now, and it's, I think, due one, parents are going to use it. They don't have a lot of choices. And again, safe, well-tolerated, efficacious. So let's look at this. So we know that type 2 receptors are upregulated in children with autism, evidence of endocannabinoid system dysfunction. And then we have a study from 2018 from Stanford that measured plasma anandamide levels, not an easy thing to do. And they found that the anandamide endocannabinoid levels were statistically significantly lower in children with autism to the point where they could basically pick out the kids who had autism based on their blood work without looking at the child. And another report out of Israel, lower circulating endocannabinoid levels in children with autism spectrum. So now we can see that there is clearly some endocannabinoid dysfunction in these patients. If you just compare a few studies that came out between 2018 and 2019, these are just all studies looking at children taking high CBD, low THC preparations. If you look there, 20 to 1 mostly. The very last one out of South America was 75 to 1 ratio. In this first study, though, they did add in THC if the patient did not have a good result with just the high CBD, and they found 52% improved on 20 to 1, and by adding in THC, another 33%. So this idea of no THC for these patients, remember they're low in anandamide. Dr. Meshulam teaches us over and over that anandamide and THC mimic each other, and why would you leave a child deficient? So I'm really anti-CBD only laws because that really limits how you're leaving a lot of patients out who could really benefit from cannabis medicine. And then I'm just going to go through, if you see in this first study, 73% remained on treatment. Again, satisfaction, patient satisfaction, right, or at least parental satisfaction. Overall improvements in 75%, 82+% remained in treatment in this study, and then 77.7 remained on treatment. And if you go through side effects, mild, mild, mild. And again, in a study, sometimes nobody's manipulating the medication to eliminate the side effect, but certainly we do that in clinical practice. And now I just want to talk about the last 15 minutes here, talk about my research. So I'm working with a group called Camformatics, and my two research partners are sitting here, Dr. Itzhak Kurek and Ken Epstein. And they approached me actually at a CannMed conference a number of years ago, and asking me to do research on what we call pharmacometabolomics, it's a mouthful as well, looking at the impact of medical cannabis on children who use medical cannabis to treat autism. And we published two papers, one at the end of last year and one just, I think, a month or two ago, looking at what's called cannabis-responsive biomarkers that we collect in saliva. And so what are these cannabis-responsive biomarkers, and what is pharmacometabolomics? So basically what you're doing is you're just collecting chemicals from the body, and you can use urine, you can use blood, you can use tissue, we chose to use saliva, and what you're looking at is these compounds that make up what's called the metabolome, which is a group of compounds that allows us to see the metabolites of the biochemical pathways. So one of the ways to look at this is that if you look at your DNA, you can see what is potential, but these biomarkers tell you actually what is going on in that human, actual data as what their body is doing in terms of those pathways. And so these biomarkers allow a clinician to kind of see where a patient is at baseline, where they are after treatment, if you stop treatment, what happens, and it allows you to see whether or not maybe there's a buildup of a certain chemical that's causing toxicity. It allows you to personalize treatment based on what we call collecting it before treatment and then following after. And it gives you numbers, it gives you data, I'm the first person to argue what the parents tell me is the truth. They are struggling and they are trying to find an answer. They do not lie, especially with out-of-pocket costly medication. When it's not working, I hear about it, okay? So people say, oh, it's wishful thinking, so they tell you that it's better. That is not true. That is not my experience. I'm sure the clinicians in the audience can tell you when patients it's not working, they tell you. But this actually gives us hard and fast objective data. And so this is not new. There are numerous studies that are published looking at metabolomics, especially for autism. And you can see here one that's looking at blood and one looking at urine. And I don't know if you tell a parent of a child with autism that you have to go get blood work, they will look at you and say, well, you're going to go with my child. I'm not going. Because that can be very, very difficult. These children have a lot of fear. People come at them with needles and so on, more so than just children without autism. So it is nice to be able to collect saliva at home. Very easy. The parents can do it. And so what we did was we had 15 children with autism who were on medical cannabis treatment that was deemed to be pretty successful. Pre meant we did a behavioral survey and saliva collection before they got their medical cannabis in the morning. And you can see on the right what we did was no medical cannabis for at least 8 hours and no food or high sugar drinks. And then we had them rinse their mouth to try to minimize any noise in that saliva. And then peak was the same thing, a behavior survey done by the parents, and then saliva collection 90 minutes after. We had 9 children typically developed who gave us saliva to establish what we call the physiologic range. And we looked at what's called cannabis-responsive biomarkers that measured different pathways. So chemicals involved in neuronal dysfunction, pain, aggression, and inflammation. And again, here is what the patient population looked like. It was mostly boys. When you look at dosage times per day, some kids took 1 dose in the morning, some took 2 throughout the day, some took 3. Edible or tincture. Edible just meant they were all these kids were on tincture, that they were putting their medicine into food and then swallowing it. So, and then you can see, as I've shown you already, the regimen was very different for most of these kids. Now, this is the behavioral rating scales before, so this is in the morning before they get their medical cannabis dose. And so 11 children were rated severe, 1 child moderate, and 2 children mild. You can see red is kind of the severe scores. And so you can see that this chart, and by the way, so along the top, this is each child. A1 is this one of the 6-year-olds, A2, A3, A4, and so on. And you can see what a heterogeneous group, right? So it's very different from child to child. Now looking, this is after they took their medical cannabis and the behavior ratings. So you can see a lot more blue, right? And what we saw was 11 children improved. 2 children had mixed response, depending on the symptoms being asked about, and 2 kids had bad days. They just exhibited increased difficulties on that day. And who knows, maybe asking them to give saliva threw them off a little bit. Or, you know, they were just didn't get enough sleep the night before. It's hard to know. But overall, we have predominant that patients were doing that they improved. Now let's look at this real quick. So this is our typically developing group. So you can see on the bottom 1 through 9, those are our patients that gave saliva. And overall, this is their biomarkers. And you can see they all kind of fall in within 2 standard deviations of each other, right? There's not a lot of variance in the typically developing children. And if you go all the way to the right, you can see the children with autism, the dark blue, that's where they fell for most of their biomarkers. And then to the right, is after you see the peak, that's after cannabis. And so you can see that it corrected, and really what we say is it shifted towards the physiologic range, right, established by those children without autism. So here's one example. So N-acetyl aspartic acid, NAA, this is an abundant neurotransmitter, and it reflects neurodensity and viability, basically neuronal dysfunction. And reading the research, you can have low levels in autism, you can have high levels in high-functioning autism. You really don't want it to be outside of that physiologic range because that indicates some neuronal dysfunction. And what we saw was 2 distinct groups. So if you look at the dark bars, right, the dark bars is they're either very significantly elevated or kind of close to the typically developing, but in all cases, the cannabis treatment modulated both groups towards the physiologic range, which suggests that the cannabis treatment is homeostatic. If it's low, it's coming up, and if it's high, it's coming down. It's stabilizing. So it's very fascinating. You can see in this graph all the way to the right, those are that typically developing group, so you can compare and you can see the differences with before and after. So this is very exciting, and this is nice to see that it's not just anecdotal anymore. That's very important. And again, this is preliminary study, so I don't want to overstate, but we were very excited with these results. And here's just another way of looking at it. This is 3 of our older kids. So the arrow pointing down, that kind of teal arrow pointing down, that's the physiologic mean, and then -2 to +2 standard deviations, which all of the children in typically developing fell within, and you can see these are, to the left is the list of biomarkers. You can see all these biomarkers are kind of off the charts on these kids, right? And then I really like this slide because it really shows, this is after medical cannabis. This is amazing, right? To see that their biomarkers shift, and it correlated with the behavioral survey. So important. All right, and here's another one. This comes from our second paper looking at lipid-based salivary biomarkers. So we had a lot of biomarkers to look at, so we separated them, and these are the lipid-based. These are compounds that are inherently involved with the endocannabinoid system as well. So here you can see the patients are listed on the left, A1 through A18, and you can see the biomarker on the legend at the bottom, the various sphingosines, I think. Is that right? And then again, here you see after they take their medical cannabis. So what we saw was that medical cannabis optimized the levels of these biomarkers in 94% of patients. So this is a tool to be used to help us personalize medicine. Finally, after 26 years of trial and error, we may be able to start using this tool at some point as we grow our database. And then one last thing I want to show you is this predictive, and again, early data, but if you look at the first patient, so these are all the biomarkers listed in gray, and the first column, which is mostly red, that's our patient, one of our oldest patients, a 12-year-old. And what you can see is all those biomarkers are significantly out of the standard deviation. And remember, the light blue is optimal, the dark blue is like, is bordering, and then the red is way out. And so what you can see is that the likelihood of this patient so this is at pre, and what we determined was that this patient is 93% likely to respond to cannabis. This would be a very helpful tool to be able to determine who to try cannabis in and who you may say, you know what, maybe you want to pursue another treatment, because remember, it's time consuming and it's costly. And so this is a very nice early result that we're hoping that with more data collection that we'll be able to really see if we can justify checking a patient beforehand to see if there is some predictive value there. These are our study limitations. Small sample size doesn't reflect the heterogeneity of autism. Unable to associate cannabinoid regimen with specific biomarker responses at this point, although there was some signaling. Now, some patients, the parents, after you're on, cannabis for a while, the parents know the dose, so they kind of eyeball it with the eyedropper, and I'm usually like really a stickler for that, using that 1 ml syringe, so they're measuring it properly, but it may have not been an accurate reflection of the dose. And then in this study, we gave equal impact to all the biomarkers, because at this point, we're still trying to sort out which ones are really important in this particular population of patients. And that's it. Thank you very much. Do you have a question, Dr. Bierman? Yeah.
So I want to put in a good word for THC and ask if you're familiar with the 1947 study by Ramsey and Davis, which showed that of the 7 people that they gave synthetic THC to five of them had a decrease of 90 to 100%.
This is epilepsy, right?
Autism. By the way, you did a great job on that expert witness thing. I have some patients that just get THC and a lot of improvement. I'm thinking of 2 particular ones. One was a 9-year-old girl. She got 10 milligrams. The parents and the teacher said she had a 30% improvement in 1 week. And the other one was the grandson of a physician, and he required 30 milligrams of THC twice a day. And he lived in a residential living facility, and when he ran out once, they called me up and said, hey, it was in a candy bar, so will you rewrite it? I did. So I guess I put in a good word for THC, and I want to know what you think about it, because these studies are all based on different doses, and we don't know what actually causes some of these things, and that's it.
Thank you, Dr. Bierman. So I agree with you. THC is an incredible compound, and we can no longer live in this world that tried to make it CBD good and THC bad. No, absolutely not. THC can do what CBD cannot sometimes. A lot of the parents that I see, look, I could tell you, I hate to say this, but I can pick out a cop and an attorney really easily. I worked in the pediatric ER for a really long time. You start to understand personalities, within about 5 minutes of walking into the room. I've had fathers who come in, they come in for the first consultation with their child having horrific seizures, and when I bring up THC, there's this, what? Like, what are you doing? And I'm like, oh, you're a law enforcement. I can tell right away. They truly have this, it's been drilled into them, right? THC is useful. I always try to include THC. The problem with THC right now, believe it or not, my patients are having a harder time accessing good quality, low potency THC tinctures than before legalization.
Yeah.
Right? What happened to all the good THC tinctures in California? Right? They kind of disappeared. There's like 3 companies where you can measure 1 milligram, 2 milligrams, 3 milligrams. There's a great product on the market. It's 75 milligrams per 1 ml. How do I dose that? 0.1 ml is 7.5 milligrams. I don't want to start with that dose in a 3-year-old, right? So I love THC. I'm very upset that it's starting to become difficult to access for my patients because, again, dosing is key. These patients that I take care of, they are very complex, and it can be the difference of like 0.05 mLs on a syringe, the difference between having a good day and having a bad day. So we want to be able to measure the THC and know the dosing and keep up with that, especially as they grow.
Hi, Bonnie, it's Ethan. Great job. You'd mentioned a problem with sucralose in Epidiolex. Was that related to its interference with the gut microbiome?
Yes, that's exactly what parents are concerned about because, they'll go and read all the ingredients. You have to remember a lot of these patients are kids that have a multitude of issues like mitochondrial disorders. I have a patient who literally the mom tries one drop in the mouth and he's had bad reaction to one drop. This is a child with what's called PANS or PANDAS. He has mitochondrial disorder, he has autism and epilepsy and a multitude of other issues. They hear sucralose and they go running in the other direction.
Sure.
And that's what it is. And they're worried about the gut and they're worried about the liver. Because when you read about sucralose, it's not exactly liver friendly.
Right. And then just a comment and see what you think. I was really struck by the Curler study that pointed out that THCA required an anticonvulsant dose of 200 milligrams per kilogram per day, and you're using nothing like that. It really appears that the rat model is no good. Rodents barely have a cerebral cortex. THCA does not appear to cross the blood-brain barrier when it's intact. But in severe epilepsy, it's not intact, and that's why I think it works at these lower doses. Does that make sense to you?
I agree. I think these patients that have excessive neuroinflammation probably have a compromised blood-brain barrier. I don't know how we're going to prove that. I think the only way that we would be able to do that is to join up with a neurosurgeon who is doing surgery on either pediatric or adult patients where they go in and they remove the loci or the focus of where the seizures are coming from after the brain mapping is done, and maybe we can try to get to look at some of the blood-brain barrier and see if we can find out if it's compromised. I don't know of any other way to do it in humans.
Sure. Thank you.
Thank you.
Hi, Dr. Goldstein.
Hi
Mike
there.
Catalano here. For your patients with autism who you said reported about a 75% improvement, what sorts of clinical outcomes were you looking at for them?
Yeah, great question. So we look at aggression, we look at self-injurious behavior, we look at ability to transition from one activity to another. That's a big thing. I've had parents who tell me their kids are getting thrown out of school because the child can't go from one activity to another and throws a chair at the teacher trying to move from one activity to another. Sleep, and then one of the biggest ones is anxiety. Kids with autism suffer some terrible anxiety. It's just, I call them Ferraris going down the freeway with pedal to the metal. And remember, a lot of the drugs that we're using for these patients just kind of put them parked. We don't want that. We just want them to go speed limit, right? We want them to be able to function and integrate into a classroom and learn. And basically what we want is them to reach their potential. And a lot of these kids are written off. They're nonverbal, and maybe they're not following directions or they're super anxious, and people write them off as, intellectually disabled. And the vast majority of my patients are not intellectually disabled. They can get the work done, they can learn. I have a patient right now who's 11 years old who has the vocabulary of a PhD student. I mean, he's amazing when he types, but he gets no credit for anything because he has all of this other stuff that when people see it, they just go, oh yeah, he's not even worth the time of day. And he has done incredibly well on cannabis. So he was a child who actually had such severe self-injurious behavior, he broke his own arm. And I mean, this is what people are dealing with. And so when we look at these behaviors, you're basically scaling irritability and aggression and anxiety and so on. Does that answer your question?
It does, thank you. And I have a second question, if I can.
Sure.
When you integrate how do you integrate the medical cannabis regimen when they're already on other medications like maybe?
When they're on their medication?
Yeah.
Yeah, so I leave medication alone for the most part, and I start with the cannabis. And I just say, I know you're anxious to wean it, but let's just leave it alone. Because if you start weaning and you're adding cannabinoids and something goes south, you don't know what's what. So my general rule of thumb is one change at a time. Occasionally, I break that rule. But what I'll do is I'll usually, just based on the patient's symptoms, if they're very aggressive or self-injurious or not sleeping at night, I will lean more towards like a CBD THC low ratio. If it's a child who's not having a lot of that aggression or self-injurious, or is sleeping okay, I'll lean towards more of a high CBD, low THC, because about half of kids will respond with that. And I was going to say this with Dr. Bierman asked me about THC. My point about saying there's not a lot of THC preparations out there that are useful now for pediatrics. There's some. I have parents like waiting for a dispensary to call them that they got the product in. And there's people here who live on that side where I text them and say, are you going to get this in? Because these people ran out and they're using something else. And the kid lost a week of his life because he couldn't go to school because all his behaviors came back because he doesn't have the proper medicine. CBD from the hemp world, if you look at the COAs and you follow companies for a while, there's a lot of good CBD out there, and the parents can order it online or go pick it up at the local health food store, and it just makes it so much easier. And in California, they're not paying that crazy high state tax along with the other taxes that go with it. So as much as I can, I do try to incorporate products that are from the hemp market because it's just easier for the families, right? But if something needs to come from the dispensary, so that's THC, THCA, and any of the low ratios, it makes it a little more difficult for families. But basically, I just try to go through each cannabinoid, and we didn't really talk about this, but CBG is a very helpful cannabinoid in autism. It's anti-inflammatory. I have patients who have become verbal on it. I see focus with CBG. And again, what are the mechanisms? We heard some lectures today about CBG, certainly a wonderful cannabinoid, easily accessed by parents as well, right, on the hemp market. You can, I don't know if you can get it in a dispensary. I don't think so. The whole idea behind the regimen takes into all these factors, right? It's just not one size fits all. I try to start with what the patient's needs are, where the family lives, their access, their lifestyle. Do they travel a lot? Because again, you're not going to be traveling all over the world with THC because that might get confiscated and then you're stuck somewhere without it. So there's a lot of things that go into how you create a regimen for a patient. But it is basically rule it in or rule it out. If something works, we keep it and then we move on to the next. I usually don't wean drugs for at least, I'd like to see a few months of stability. And when you get that improvement, parents always say, how am I going to know? I'm like, you know. You know your child, right? So we all know our loved ones. We know when they're having a good day and a bad day. And so if you watch over time after a few months and the child's doing well, you can start to wean. Don't be surprised if you have to give more THC while you're weaning a drug or more CBD, because sometimes it is doing a little bit for the patient, or just removing it, you have to start, it throws them out of balance and you have to get back into balance.
Thank you very much.
You're welcome.
Hi, Marley Cole. I'm from Utah, but I asked you a question yesterday, and I think that your answer was just phenomenal, and I think everyone could benefit from it. So your opinion on medical cannabis inhalation for children and how young they can inhale for acute symptoms. Obviously, we don't want them smoking a joint or a bong or something, but still, would you prefer them try vape cartridges and or a dry herb vaporizer?
Right.
Yeah, just elaborate on that.
Right. So my experience with vaping in children is pretty extensive. So I have a handful of pediatric epilepsy teenagers who get auras, which is the sensation that a seizure is coming. And if they vape THC or a 1-to-1 CBD THC, it stops the seizure from happening. And I've seen it over and over in certain patients. So I have no problem with them using an vaporizer. And either I don't want to endorse a company here, but there's a company here that if you take a puff, the device vibrates, kind of like your phone vibrates, and that's like about 2.5 milligrams, depending on the makeup. And a lot of parents like that because they know, oh, okay, it's kind of close to dose, it's a dose, right? They're not sucking on the thing. And then I do have some patients who have rage with autism. They're aware of their rage. They know that they get into this, kind of escalated, they feel that anxiety, and they will ask for a puff. They will go to their parent, and they either use a flower, vaporizer with flower, or they'll use one of these other vape cartridge devices. I have not seen any issues in these patients using inhaled for basically rescue. Think about, right? It's rescue medicine. So this is not unusual in epilepsy. There's nasal rescue medication, there's rectal Valium, there's all kinds of rescue medicine out there. So certainly there's no reason that we can't use this, and it is quite successful. Now, when you ask me the age, I don't think I've ever had anybody under 8 use a vaporizer. I'm not sure. Dustin, have you had any patients younger than 8? No? Yeah. So, they have to be able to do it. Now, I do have a family, and I showed them on Tuesday, this brother-sister. So the brother has epilepsy, autism, cyclical vomiting syndrome, and a genetic abnormality. He's done incredibly well. He's in my book. His name is Gavin. And when he gets a cyclical vomiting episode, the parents have a volcano vaporizer. They have homegrown Granddaddy Purple, and they put him in the bathroom, and they ramp up their volcano. He's been able to avoid emergency room. I mean, they were at the ER every month for the longest time, and he's on high-dose CBD and THC. Whatever it is that triggers him, when it goes, it goes. And so this has really helped. His sister, when she got COVID, had a seizure, first seizure in 4 years, and she caught it at school, even with the mask on, and she had her seizure, and she seemed like she was going to cluster a little bit, so I said, go ahead and just use the volcano on her. And she recovered. She didn't have any further seizures, no clusters, no nothing. I mean, it works. Now, they both don't like it. They scream bloody murder, and that's why they go in the bathroom, because they don't want the neighbors calling the cops that the kids are getting. But they don't like the device over, So what they did was they took the volcano and they kind of rigged up a little pediatric oxygen mask to it. And there's a video online that you can see, a patient in Texas who's very well known, a young lady with severe autism, is very self-injurious, and her parents have the volcano always ready to go, and they just kind of got some tubing, they got a pediatric mask, and they give her the vape, and you see her very unhappy to very happy very quickly. So I think it's something that we cannot disregard. It's something that should be included in many of these pediatric cases.
Thanks a lot for the presentation. I just want would you mind clarifying your comment regarding the effects of CBD on the patient microbiome? Because I sort of hear you were saying something regarding the susceptibility of the patient due to mitochondria. So I was just curious. I want to.
Sorry, I don't understand the question.
The question.
Like, what does CBD do to the microbiome?
Yeah, what does CBD?
Well, so remember, CBD enhances your CBD has tons of targets in your body, enzymes.
In autism patient.
In autism patients.
And then the first part, and the second part of the question is, we have a panel earlier today that talk about how regulation in different states in this country. Now, right now, there is no difference in guideline, across this country for microbial contaminant testing for recreational and medical cannabis. I was just wondering if you have any insight, moving forward, should there be a different guideline for medical cannabis and recreational cannabis? Thank you.
Right. Oh, that's a good question. I don't know that I'm the right person to answer that second question. I will tell you that so far I haven't had anybody get sick, even in the unregulated market, because we're always very careful with pediatric patients. We never really use a product unless the parent's doing it, like went rogue and is doing it on their own. For me, it's a deal breaker if I don't have a COA. That's it. So I have a COA, so I can always see what the patient is on. And we can also look at batch to batch to see if there's any change. You know, early on back in 2008, or I should say really 2013, I had patients that would start with one product and get great results and go right back to the same company or the same cultivator, processor, and get the oil exactly labeled, exactly the same thing. And they'd say, oh, my child's not responding anymore. I'd say, it's not the same, but it's different. It's a different chemovar. It was made different. We don't even know what's in there. We have to get a COA. And that's when I started looking at COAs, was very early on, when my patients were getting very inconsistent results. In terms of the microbiome, that's like a whole lecture, and I would refer you to Ethan Russo's paper and also to the Care and Feeding. But basically, remember, CBD enhances your endocannabinoid system by allowing anandamide to hang around a little longer. It blocks the breakdown of anandamide, or encourages that pathway. And so by establishing an enhanced endocannabinoid system, I mean, that's the whole idea behind cannabis, is that we're augmenting the endocannabinoid system to get it back into balance.
Hi. So about 10 years ago, I was having all these IBS symptoms, and so I started reading about people juicing. And so I decided I would juice, and this was before I was going into the office. And I figured, oh, it's THCA, I'll be fine, because it was fresh material. And I ended up getting really stoned, and I was like, what the hell is happening? I figured, oh, there must be some decarboxylated material in here. And so I tried it again. I got stoned again. And anyway, it led me to question whether in people with certain acidic stomach conditions, whether there could be THCA essentially decarboxylating in the gut. And Ethan's question about why THCA appears to maybe be effective, and the hypothesis that maybe it has to do with the blood-brain barrier, having a breakdown in these kinds of patients. I think we might also look at variability in terms of pH levels in the gut of these patients, because obviously we know that pH is associated with microbiomes, et cetera. So I'm wondering if you've seen anybody take THCA and get high, and second, whether you think that might be a good hypothesis for somebody to pursue. Now that I'm not in the cannabis game, I'd love to see somebody pursue that research.
Well, I think it's already been done, and I think that we've discounted that. It does not appear that THCA converts to THC in the body, and nor does CBDA convert to CBD in the body. So I could look up those references and share that with you. In terms of getting high on THCA, sure, I've had patients get high on what's reported to be THCA, because remember, by the time my patients get it, they're usually not using whole plant or raw or plant material. It's usually been processed somewhere along the line, and it depends on how long it was sitting on a shelf. Was it kept in a refrigerator? Did it get exposed? Like, was it sitting in a truck where it sat outside a distribution center in the hot Southern California weather? So it's hard to know, because there will be conversion in that bottle. There's always some THC in a bottle of THC. We just don't know how much. Now, there's one product that I've been using with my patients that's like a 20-to-1 THCA to THC. But there's also products out there that have THCA and CBD. There's products out there that have THCA 1-to-1 with THC. So you have to read labels. You have to know what you're getting, and I highly recommend keeping it in a refrigerator. If it's not in a dark bottle, put it in a dark bottle or wrap it in tinfoil, because every time you open and close the refrigerator, there's some light getting in. So in order to maintain it as close to, it's like when you purchased it. But again, before buying it in a dispensary, you have no idea what happened to it. So it certainly could contain a lot of THC. And that's why I always tell patients to always start with a low dose. I'm not sure why you became so intoxicated. Maybe maybe Dustin has you have an answer, Dustin?
Was there friction? High-speed friction?
Yeah, I suppose it could have been cavitation from juicing. I was lucky enough to have access to a mass spec, and so I took what I had and I looked at it, and it was THCA.
Oh.
So I think that and I'm familiar with the data that you're talking about. I don't think that that data at all accounted for people with gut conditions
I
specifically.
agree. Yeah, there's
So-
probably some variability, sure.
Yeah, so I think that there's potentially a pH issue happening, because when I tried the THCA, when I wasn't in an acute, episode, it didn't get me high.
Yeah, that's
So,
interesting.
yeah.
And I tell people, like I have parents that say, oh, is this going to make my child high, or is it going to make them agitated, is this going to make them calm? I say, all bets are off, don't guess, just try it and see. Because it's very hard to guess with cannabis, right? It's polypharmaceutical to start with, right? There's lots and lots of compounds. We want them all in there, but you just don't know which person's going to be sensitive to what. And then, last night, listening to Deddy speak, he found these go to sleep 1 and go to sleep 2. We're not even accounting for all of the compounds that we have no idea, right? But I really believe, again, the information we have at this time is that cannabis is safe, it's well tolerated, and I don't really have any qualms about treating pediatric patients with it, especially under medical supervision, because really things don't go south too often. So thank you for your question.
Thank you, Bonnie. Oh, excuse me. Thank you, Bonnie, for all your work with pediatrics. You and I share that field. But I had a question twofold. With the biomarkers that you saw, you think that might help with early detection of autistic children? And also, would we look at maybe dosing these children early on, very early ages, and will we slow down the progression of autism, or at least help with development?
Yeah, great questions. Thank you. So yes, I do think that these can be used as biomarkers. Once we have more data and we're able to really see which ones are very highly elevated and are consistently elevated across, remember, it's a spectrum disorder, so we want to be able to have the best idea of which biomarkers correlate the best. I absolutely think that would be great. And I mentioned this the other day, that you might be able to use plasma anandamide levels as a biomarker for autism as well. So there are a number of things that we can look at. Maybe we do anandamide and biomarkers, and we see if there's some correlation there as well. I'm sorry, what was your second question?
Second one was, if you start these children...
Oh, right. Yeah. I do think starting them earlier would be helpful. And someone might say, how early? I mean, the youngest patient I've ever treated was a 6-week-old with a severe genetic seizure disorder that was likely having seizures in utero. I couldn't treat them until I had the diagnosis. At 6 weeks is when the genetics came back, and we started treatment, and that child did fairly well. It was a devastating metabolic syndrome, so I don't know how good we're going to be able to get that child, but I certainly wasn't going to wait and let him continue to he was having hundreds of seizures on his EEG a day. And, and then are you going to give a 6-month-old a multitude of anti-epileptic drugs? I mean, right? Do no harm. So he did okay. I mean, he had much less seizures. We never got him seizure-free. And it's not, this group of patients that have refractory epilepsy, look, I have had patients that have tried up to 22 different anti-epileptics. You're talking about a long time to try these. You're losing brain cells as you go. To me, if you're really hardcore and want to try 1 or 2, go right out of the gate. But I do always think that it's worth a conversation in the beginning. Why not use the benign plant? Now that we have so much data, why not try it? What if your child is the child that's going to respond and you don't have to go down that pathway of those hardcore drugs that do cause a lot of somnolence and all other kinds of side effects?
Hi. Well, thank you for all your work, first of all. My question was regarding the marker for your research study about sleep. How do you guys measure the sleep efficiency in autistic children?
Was that a study that I quoted for sleep?
I believe you
was it-
asked, actually, you answered the question about the markers, and one of your markers for your research study was sleep for the
I
improvement.
don't remember which one. Itzhak, do you have, did we have a biomarker for sleep? No, I think it was inflammation, pain, neuronal dysfunction.
Oh, okay, sorry. I thought you mentioned sleep, so I was just
I
wondering
only
if it was polysomnography or it was actually sleep diaries.
Yeah, it's a good question. I did mention sleep in one of the EEG reports. And what they did was they had the children or the patients in that report did wear the EEG suit through sleep. And so they did have brain waves looking at the quality of the sleep and what they call the microstructure. And it was like something over 75% of those patients had improvement in their sleep microstructure based on an EEG.
Okay. Was that just a portable unit probably, right?
Yeah.
Okay, thank you so much.
Yes, I'm not sure where they did that, yeah.
Hi, again, thank you. Amazing work. The gut microbiome being so important, are any of these kids following a special diet, like a low-carb, vegetable-rich diet, or is that just impossible?
No, it's not impossible. It's, you know, it's hard when you have a special needs child to then also control everything that goes into their mouth, especially when they are super, super, super picky.
Yeah.
And they have problems with textures and so on. Some of my patients are gluten-free, dairy-free, sugar-free, and some are the exact opposite and come in my office with the ring of Cheetos around their mouth, and I try not to look at that because that's not even real food. But I always tell parents to try dietary. I always encourage it. Just give it 3 months of gluten-free. It's a lot easier to do gluten-free now than it ever was because there's so many gluten-free options. Even here, there's gluten-free. When you go out to dinner, they mark on the, you know, on a menu. But many people are reluctant to do it, and I think part of that is they don't want to do gluten-free, and they don't want to have to prepare a meal for their child that is special, and then everybody else is eating something different.
Oh, no, that won't work.
Yeah, that won't work either. So it's a challenge. It's a great question. And some people do it hardcore, and other people, when I mention it, just say that's last resort. So
Do you find that the ones that are doing it get better results?
it's a good question. I would say that the ones that stick to it are sticking to it for a reason, because they see. And remember, too, that once your child's old enough, you don't have control over what they eat, right? They go to a birthday party, or they go to a, you know, they're in high school.
Yeah.
And so, again, it's a very hard thing. More so in the pediatric epilepsy group is the ketogenic diet.
Yeah.
But that is, parents will do that at all costs, because when you live with intractable seizures, if just tweaking the diet, and usually for ketogenic diet, they have a dietitian as part of their neurology appointment, and they just get so much assistance for that. I don't see as many parents seeking that kind of nutritional assistance with children with autism, although you could. I'm sure that you could see a nutritionist or a dietitian to help you with that. But it's a great question. I think it's a whole picture, right? You know how for autism, one of their little logo is the puzzle piece?
Yeah.
That's what it is.
Yeah.
Cannabis is just another puzzle piece, and so is the diet.
Cool, thank you.
Thank you. Any other questions? Thank you very much, everybody.